Good morning, everyone. Thanks for the organizers for the invitation to speak on imaging modalities for uveitis, current perspectives. So in the next 10 minutes, I will try to illustrate some of the thinking I have about imaging in uveitis and how I think it has helped me in my practice and in my patients, and hopefully you'll find the same too. No conflicts of interest? So the first question is, why actually is imaging necessary in uveitis, correct? We always try to rely on our clinical history as well as our clinical examination. So let's just take the most common example and the most sight-threatening complication of uveitis, uveitic macular edema. So I would say no one here would now diagnose uveitic macular edema without an OCT. But when the OCT was a novel instrument about 15 years ago, people have actually done studies and realized that ophthalmologists were missing up to 40% of macular edema and misdiagnosing another 17% of patients with macular edema. We now have great tools with our machines for longitudinal follow-up. This is the Heidelberg Spectralis platform. You might be using Topcon, you might be using Zeiss Retinal Workplace. But these shows how powerful it is for longitudinal follow-up of disease progression and treatment efficacy. And related to that, you can understand a picture speaks 1,000 words and how important it is, especially uveitis being a chronic disease. A tool like this can be used for patient education as well as medical legal documentation. Lastly, looking at research, we know that uveitis clinical trials are besieged by subjective outcome measures like visual acuity, vitreous haze. Imaging may help us try and quantify these areas. So let's go into some of the thinking I have about imaging. Firstly, we have multimodal imaging available right now, and I often think of imaging in two ways, structural and functional, and I organize them in a step-ladder approach from the most available, cheapest and repeatable to those that are slightly more invasive. You can appreciate here the case for ultra-wide field imaging. On your right, you see the 200-degree field of the Optus camera. There are other wide field platforms like the Zeiss, and this is compared to your direct and indirect ophthalmoscope as well as your 90-degree slit lamp. You will understand in uveitis we have many patients who are uncooperative, pediatric patients, dense cataracts, small pupils, posterior synechiae. So you will feel how easily it is to miss things if you do not have wide field imaging. On your left, you see relatively normal fundus photographs, but the angiogram shows highly active posterior uveitis, right? This is a situation we all face. And these two studies actually show that with the addition of wide field color fundus photography as well as angiograms, up to 3 times or 5 times the number of patients have their disease assessment changed and management subsequently changed. So my take is that if wide field imaging is accessible to you, do consider using it. So from the peripheries, we go right down to the posterior pole, something that we all feel is easily accessible, easily accessible as well. On your right, you see a list of causes of reduced and increased autofluorescence. And I think autofluorescence is a great tool to assess the posterior pole when the patient is complaining and we see nothing. And these pathologies generally lie in the outer retina or the superficial choroid. So let's go into some case examples. This is a 30-year-old male who complains of visual disturbances after a bout of viral infection. You can see the Zeiss color photo on the right, on the left eye, essentially normal. But on the autofluorescence, you see the dots and spots in the parafoveal region, typical of Mutes disease. This is another young lady, 42-year-old. If you are really astute with your 90-degree diopter lens, you may argue that, oh, this right retina looks a little bit pale, the vessels look a little bit attenuated, the sheen is not there, the choroid looks a little bit more apparent. But on the autofluorescence, you really see this mixed granular hypo autofluorescence in the peripheries, only sparing the central 10 degrees of the fovea. This patient eventually was diagnosed with autoimmune retinopathy. Just one more. So again, a relatively normal color fundus photograph of a 50-year-old lady complaining of flashes and floaters. But on the autofluorescence, you see this annular hyperautofluorescence around the disc extending towards the temporal arcades. Eventually, this patient had an ERG and was diagnosed with azole. This is one of my favorites, VKH, something extremely common that we can see in our own practice. I think you will agree with me that the autofluorescence photos really demonstrate the extent of the exudative retinal detachment far better than the color fundus photos. So consider using this. So we have talked about the peripheries, we have talked about the macula. Now, not only describing the physical changes of the eye, we also need to continuously upgrade ourselves and understand what the imaging is telling us. And here I would like to speak about OCT biomarkers. This diagram shows you how far OCT has come. Right now, OCT is an instrument that can enable us to image from the vitreous all the way down to the choroidal scleral interface. And there have been much work by very intellectual people in these fields trying to give clues to the etiology of uveitis patients through OCT biomarkers. From the infectious portion, you have the pre-retinal as well as retrohyaloid deposits that try and differentiate between toxo and viral retinitis. Here again, you see the choroidal involvement in A and B panels, signifying a more likely toxo cause as opposed to C and D, with the choroid relatively spared and more likely viral retinitis. Here you can see the rain cloud sign in fungal endophthalmitis. And not only infectious, but also in inflammatory uveitis, the bacillary layer detachment that has been described first in toxo, but now realized to be most common in VKH, and is a good differentiating sign with CSCR. Here you see the sign described by David Saraf's group, the ASH sign in MP. And lastly, if you look at the fundus photographs of these patients, one might be not faulted to think that this is viral retinitis. But if you look at the OCT, it demonstrates rounded roof appearance, infiltration of the inner retina, and outer retinal undulation. This patient was eventually diagnosed with primary vitreoretinal lymphoma. So there are newer developments on the horizon. No talk about current perspective can leave out the debate between OCTA and dye-based angiograms. I am not going to that because I'm not an expert, but I will refer you to this excellent editorial which people have written to try and allow us to understand the place of these two imaging modalities in our practice. Moving on, automation is a big thing now in ophthalmology and all of medicine. So people have also tried to use machine learning and artificial intelligence to quantify AC cells and vitreous haze. All these will probably serve to strengthen the need for imaging in our future uveitis patients. So in summary, I leave you with 4 points. The first is that nothing can replace a good history and a physical examination, but stepwise imaging is probably necessary in this day and age for our uveitis patients. If it is accessible to you, do consider ultra-wide field color fundus photography and angiograms because they tend to pick up much more lesions and change management as compared to the traditional 30 to 55 degree views. We also need to continuously upgrade ourselves because imaging biomarkers have shown that it can clue us in on various etiologies of diseases. And lastly, future developments in the imaging sphere will probably serve to make multimodal imaging more essential in uveitis practice. I thank you for your attention.